You're listening to the Addiction Medicine Podcast, the official podcast of the Governor's Institute. If this is your first time listening, thanks for joining us. The Addiction Medicine Podcast is designed for healthcare professionals and others interested in addiction medicine and will feature thoughtful conversations and insights from clinicians, patients, and families, policymakers, and other stakeholders. Remember to make us a favorite wherever you get your podcasts. You can also stay connected with us at governorsinstitute.org or follow any of our social media channels at @govinst.
Hi, I'm Pauline Williamson, Director of Physician Initiatives at the Governor's Institute. We ended part 1 of our conversation about sexually transmitted infections, talking about the role of the healthcare provider. We are continuing this discussion and will be addressing STI screening, prevention, and treatment with our experts. Dr. Shannon Dowler is joining us today, and she is a board-certified family physician living in the Appalachian Mountains of North Carolina with a national reach and expertise in public health policy, public payers, and health equity with a special interest in advancing sexual health, reducing sexually transmitted infections. And she's currently the deputy director in the Mecklenburg County STI Clinic and consulting with Health and Human Services on the National Syphilis and Congenital Syphilis Syndemic Federal Task Force. She's also the immediate past CMO for North Carolina Medicaid and Assistant Secretary for Health Access with North Carolina DHHS. Dr. Amy Marietta is board certified in family medicine and addiction medicine, and she's the medical director of Mayhec's Project Cara, which is a comprehensive perinatal substance use treatment program in Asheville, North Carolina. She's passionate about caring for pregnant and parenting people with substance use disorders, and she is working to bring these services to more people in rural communities. So thank you once again for joining us for part 2 of these podcasts. So let's jump right in and start off with screening. What are the best practices for screening for STIs? Dr. Dowler, you first.
All right. So this is a really complex answer. I think thing one, if you get nothing else out of this podcast, you need to go to your phone apps and download the CDC app. It's the STI treatment guidelines. Everybody needs to have that free app on their phones. It addresses screening, prevention, and treatment based on the prevailing guidelines. So they keep it constantly updated. And it keeps you from having to pack all this information into your brains or trust a Google search, because no telling what's going to come up with that. It's really not uncommon for us to see people that come to us in the health department, or we get a disease report form and find out that they were treated inappropriately. They were treated on guidelines that were 5 years ago and not today's guidelines. And so we have to restart the whole process for them and their partners. So CDC free app, STI treatment guidelines. For screening, even when I'm in my primary care clinic and not in the STI clinic, I want every new patient to have a thorough sexual history and screening at all sites of exposure. It's sort of your kind of control alt delete. No telling what they've had before you've seen them. There's no telling how honest they were with their prior providers. So do a really detailed sexual history and screen all sites of exposure. From there, it really depends on risks. Even people in monogamous relationships can get infections because not everybody is always monogamous, or what some people consider sex, other people don't consider sex. So annual screening and sexual history review is really important because people do have one-off hookups. They might not identify as gay, but they have one random hookup partner. So you really do need to renew those questions periodically. When you have someone who is high risk, meaning they have several unprotected partners, they're using hookup apps, they're trading sex for drugs or money, men who have sex with men, or trans women, I would test every 3 months at all sites of exposure and really hone in on ways you might help them prevent infection. Finally, when anybody ever changes partners, they should have testing. So they arrive with their new partner in the best way possible. I feel like as a parent, that was like the most important thing I taught my sons is when you're going to change partners, you want a clean bill of health. So always go and get tested. And what's been interesting to me is how hard it has been for them to find timely and accessible testing. And so this is not an easy path, but if you are seeing the person, they're in your office, please make it accessible and available.
Great. So what are we seeing with the pregnant population?
Sure. So the best practices for screening in the pregnant population are that pregnant patients should be screened for sexually transmitted infections, including gonorrhea and chlamydia, syphilis, HIV, hepatitis B and C, as soon as possible after that first positive pregnancy test, but at the very least upon entry to prenatal care. And in some cases, testing for trichomonas and herpes virus may be indicated. And then screening should be repeated for syphilis and HIV at the beginning of the third trimester, so around 28 to 32 weeks, and then again at delivery. Screening for gonorrhea and chlamydia should be repeated at about 36 weeks of gestation, so about a month before their due date. And then individuals in labor who have not been screened in pregnancy or have not had any prenatal care or have a stillbirth after 20 weeks of gestation should also be screened at delivery.
And can I jump in on that and say that one of the things that the task force, sort of at the federal level, we've been struggling with is that the guidelines are different everywhere. So if you look at the USPSTF and you look at the CDC and you look at ACOG or AAFP, the guidelines are really sort of risk-based screening guidelines for syphilis specifically. But in North Carolina, we have state statute. It is the law that you check at that first prenatal visit between 28 and 30 weeks and at delivery. And in fact, in North Carolina, state law says baby can't be discharged home until mom's syphilis test results are on the chart. It doesn't mean people are necessarily following it, because some of the cases we've investigated have been people who have been in prenatal care and not had that testing done. But North Carolina is kind of ahead of the game and having state law around this.
Very interesting. So screening is obviously a really important part for healthcare providers to be paying attention to and doing. What are some of the best practices for actually preventing STIs? Dr. Dowler, you first.
So I think of it in three categories. So category one's barrier methods: male condoms, female condoms, dental dams. As we know, it's not going to be effective a lot of the time because people aren't going to use them, or cost is a challenge, where it's just preference. They don't want to use them. The next bucket I think about is vaccinations. So hepatitis B and HPV vaccine should be part of your history. The guidelines for HPV vaccination have pushed it later and later in life. So if a teenager misses it, they can get it much later. Like if mom and dad did not want them to have, the STD vaccine, even though it's really a cancer vaccine, we can give it to them in their 20s, 30s, even 40s. So we need to make sure people are getting their HPV vaccine. It's going to prevent cancers later in life, not just cervical, anal, penile cancers, but head and neck cancers as well. The third bucket is medication. So we've had some big advances over the last decade here. HIV PrEP, pre-exposure prophylaxis, should be offered to any high-risk patient. It is incredibly easy to prescribe and to manage. I mean, it's really simple. So folks should be using PrEP all the time when they have high-risk populations, or at least offering it and creating a safe place for people to get it. There's something called a PrEP to need ratio, where we look at the amount of PrEP being offered based on the need, i.e. the number of new HIV cases. And we do poorly at this in North Carolina, and particularly along that I-95 belt of where there's a lower access to care. The PrEP to need ratio is really unfortunate. So PrEP should be in your toolbox. The newest advance on the prevention front, this is really, really new, is called Doxy PEP, or doxycycline post-exposure prophylaxis. I was so excited about Doxy PEP that I named one of my new baby goats Doxy. So the CDC just came out with their guidelines on how we should be using this in certain high-risk populations. They're not recommending it for everybody, specifically not for cis women. If you're taking care of a population that's actively dealing with substance use disorder, you should be talking about whether they would be a good candidate for doxycycline post-exposure prophylaxis.
Great. Dr. Marietta, can you discuss the importance of partner treatment to prevent reinfection as we talk about prevention?
Sure. So we can reduce the risk of reinfection and increase success of treatment by treating partners. So one way to do this is through expedited partner therapy. And this is when we facilitate treatment for a known sexual partner or partners by giving an antibiotic or prescription to the diagnosed, or what we call the index patient, the first patient that has the infection. And so they can provide it to their partners, or we as providers can call in a prescription directly for the partner. And those partners who are going to be treated should also be provided with information on the importance of treatment, the symptoms of complications to watch for, and potential adverse effects of therapy.
So it sounds like the use of medications and, of course, preventing partner reinfections. This is harm reduction. Dr. Marietta, what are some other harm reduction strategies that we can keep in mind?
Sure. So, everyone has heard of harm reduction, right? So if you wear a seatbelt, if you use a bike helmet, you are engaging in harm reduction. We do things that have risks. And when we do things to protect ourselves and reduce the chance of risk from those activities, that's harm reduction. So harm reduction in the substance use disorder space is based on a fundamental respect for the dignity of people who use drugs. There's so much that we can do to reduce risk, no matter where someone is at in their journey, right? By meeting them in a safe and non-judgmental space. And then we talk about several specific strategies for harm reduction. So we can mitigate the harms of ongoing use by ensuring that people have access to clean supplies, safe supplies like needles or syringes. Overdose prevention is a huge part of harm reduction. So ensuring that people have easy and quick access to naloxone or Narcan, and that patients and the people surrounding those patients know how to use it to prevent an overdose death. I carry it in my own bag everywhere because you never know when you might need it. And I would encourage you to do so as someone who just lives and walks in the world. We also encourage people to never use alone, to go slow when starting, especially with like a new supply, and to use the Never Alone hotline if they're considering using by themselves. The Never Use Alone hotline is a great opportunity for someone to connect with someone who can actually sit with them on the phone while they're using, and then gets the information so that they can call EMS in case the person becomes unresponsive while they're using. It saved lives. So supplies that might make use less dangerous, like fentanyl or xylazine testing strips, can be really helpful in harm reduction. And then just meeting people where they're at and ensuring that when they are ready, when they finally say, I think I need to do something different, or, I had a friend die last week, I need to talk about getting into treatment. Make sure it's easily available. What I always say, I hope that I get to go on treating my patients' sexually transmitted infections because it means they're alive. And as long as you are breathing, there is hope. So as long as we can keep you alive, we have an opportunity to keep walking towards, what is next for you. So that's, for me, what harm reduction is all about.
Absolutely. So again, in the spirit of harm reduction, Dr. Dowler, talk to us about barrier methods.
So barrier methods are kind of boring. People don't like them. But I will say condoms are free at just about any health department you walk into. You can purchase them for, on average, 50 cents per condom. Interestingly, the female condom, which is where the woman has control of her body and how she wants to protect it, costs like $5 per condom. Dental dams are somewhere in between, but if we're honest, I've only run into one patient who uses them. So I think the one thing that could be really helpful in the universe is if we could have healthcare providers all make barrier methods accessible. And maybe it's just condoms that you want to have, but make them accessible for your patients. Don't make them ask for them. That's embarrassing for them. Have them available in every exam room. If they take a bunch and they give them to their friends, great. Winner. So one thing I will say, I just learned about yesterday. I'm so excited. One of the things I had tried to do when I was at Medicaid and failed to do was to get condoms covered. But as of September 1st, North Carolina Medicaid is going to be covering condoms and spermicide, which is fantastic that it's going to be a covered benefit, 50 years late, but whatever. So they're going to be covering that. So, but we in our exam rooms should always have condoms available to people. It does not cost much money. People do not hoard them. And get the good ones. Don't get the cheap ones. Get the fun ones that have interesting patterns and designs on the packaging, because people are more likely to grab them and use them.
So as much fun as barrier methods are, the logical next step in our conversation is to talk about treatment. To do this, let's talk about some of the important issues in the treatment of STIs. Dr. Dowler, are you able to share recent guideline changes and talk about issues with medication access?
So I'll start with sort of a hot topic, which has been in the setting of the syphilis syndemic, this shortage of bicillin we're experiencing. So the drug of choice for treating syphilis, and the only drug for pregnant persons, is long-acting benzathine penicillin. The only producer of that in the United States is Pfizer, and under the trade name Bicillin. There was a shortage of that. And so we had to shift guidelines to say, okay, you can use doxycycline in non-pregnant persons while we get supplies up. Meanwhile, we got an import of lenticillin, which is very low cost. We got an import of extensiline, which costs the same as Bicillin. And now Pfizer's got their production up, so we're good. So we don't have that shortage anymore. The challenge is it's really an expensive medicine. And so if you don't have access to 340B pricing, if you're in a regular practice, stocking that medication, it's $400 or $500 per injection for you to stock that in your office. So you have to put out a lot of money just in case someone comes in with syphilis. So you can send people to the health department and get it at no cost. Of course, then you're adding complications to things. The newest, the lenticillin that's in temporary import, is $15 per dose. You need actually 2, so it costs $30 as opposed to $400 or $500 for a practice. So we are seeing more options becoming available. Most treatments for STIs broadly have a generic form, and so they're pretty affordable. You can also go to your health department and get those medications at no cost. The exception from a cost standpoint of STIs is the treatment of Mycoplasma genitalium. That's pretty expensive, even if you have 340B discounted pricing. And HIV PrEP, pre-exposure prophylaxis, can be expensive, but payers all cover it, and there's a federal program that covers the uninsured. So, and the drug companies themselves have lots of benefits, so cost of that drug shouldn't be a barrier. From a guideline standpoint, historically, the CDC used to update their guidelines every 3 to 5 years. And I know that I used to get really antsy. When 5 years had happened and they hadn't updated the guidelines, I'd be calling the CDC and sending them messages online. So they have recently expressed their intention to update the guidelines real time on a rolling basis. And this is fantastic news. So instead of us constantly waiting for the big publication, we'll be getting snippets when there are changes that come out in the world. In the last guidelines that was released, the biggest change was probably chlamydia treatment. So we shifted from a one-time dose of azithromycin, Zithro is one of my other goat names, I should say, to doxycycline. And so there are occasional times when you might use Zithromax, but doxycycline for a week is really the better thing. And the U.S. finally came out with our first formal guidelines for testing and treatment of Mycoplasma genitalium. And that is for people with persistent or recurrent urethritis or cervicitis. And we see that a lot in clinic. I used to call these people sort of the worried penis, because they come in with like symptoms over and over again, and their test would be negative, and we'd be like, oh my gosh, they're just worried. Well, it turns out they might have MGen. So we now have some guidelines for that. Treatment is with 2 weeks of 2 different antibiotics. Moxifloxacin, which is also the name of a goat, I should say, is one of them. And so that is probably one of the biggest changes that came out in those guidelines. More and more STIs are identified. Like, it is hard to keep up. I've got this running list, and I use it as sort of a way to break the energy when I'm starting a presentation. I try to see if people can name all the sexually transmitted infections, and I have yet to find an audience who can do it. So using that CDC app to help you stay up to date is really helpful, because there's just so many of them, and the guidelines are constantly changing.
So, Dr. Marietta, can you tell us about what medication access for the pregnant population and potential medication allergies that you might want to consider?
Sure. So many sexually transmitted infections are treated differently in pregnancy than in non-pregnant persons. So, for example, doxycycline, like Dr. Dowler just mentioned, it's used to treat chlamydia or syphilis in non-pregnant people. It's avoided in pregnancy because of potential harmful effects on fetal bone and teeth development. So for like the case of syphilis treatment, unlike with non-pregnant people, doxycycline is not recommended as a treatment choice. So pregnant patients who have a penicillin allergy will need to be hospitalized and sensitized to receive penicillin treatment. And that obviously happens with close monitoring and consultation from specialists.
So from here, what can you guys share about managing test results?
Yeah, so it depends on the environment you're in. You'll manage test results differently. It's really important that if you have a reportable infection that's that's reportable in North Carolina that you complete the disease reporting form. This is really helpful for a couple reasons. One, it's just helpful for tracking in general, but even more importantly, it tells us at the health departments if your patient's been appropriately treated, so that we can just, file that form and know that you did the right thing in your clinic setting and you gave them the right treatment. If we don't get that disease reporting form, and let's say we find out on the back end from a lab who does a lab dump of reports, then we have to go to your office, call your office, request records. It's a hassle for you. It's a hassle for us. And we really have these hardworking health department staff who are super limited that could be doing other things. So disease reporting is really important, not just for tracking infections, but for making sure that treatment is appropriate and has been done, and that partners then begin to get tested. Probably from the test result that's going to wreck your day, syphilis wins. Syphilis requires 2 tests. You can't just do one. Providers often will send people to us for treatment of syphilis at the health department, and they've only had 1 test. They didn't have that confirmatory test. Well, that wastes a lot of time and energy for your patients. It doesn't make you look great. Patients are annoyed. So syphilis is hard because there's 2 tests. And you can do it in a traditional algorithm or in a reverse algorithm, which makes it even more complicated depending on who you send your labs to. CDC has some fantastic resources and algorithms to help you manage those results. You can always call your local health department, ask to speak to the medical director or a disease control nurse, and they will help you get through this. Your local disease intervention specialist can also be a big help if you're in contact with them. And then if you can't get the answers you need, you can always just go to our state STD division for support. They are happy to take your calls and help you work through these solutions, especially when you're talking about the higher risk populations.
Great. So next, what do we need to do about follow-up care?
So first of all, I just want to give a big shout out to my local DIS specialists. They are an incredible resource, and I'm so eternally grateful. If they're listening to this, thank you. But, when we think about following up on test results and retesting, in many cases, a test of cure is recommended after treatment. So, for example, a test of cure is recommended 3 weeks after treatment of gonorrhea or chlamydia to ensure that it's been treated and there has not been a reinfection. And then follow-up testing may also be indicated even in the case of a negative initial test. So for example, if someone has a possible exposure to HIV after an initial negative test, we repeat HIV testing within 4 to 6 months to rule out any infection that may have happened in that initial window period after infection. And that's a period in which testing may be falsely negative. So we want to repeat it. So there may be follow-up guidelines or tests of cure that need to happen even after treatment or negative initial testing.
Yeah, and I'll add on to that and say that we talk about test of cure and test of reinfection. Test of cure is really thinking about drug resistance. So we're thinking particularly in gonorrhea, we have crazy drug resistance. We just had our first total all antibiotic resistant gonorrhea hit the US last year. And then test of reinfection is that, did the partner get tested and treated, and or are they just playing ping pong and they're giving themselves the infections back and forth? So doing these follow-up tests are really important because we'll catch people who either have drug resistance or, more commonly, they just got reinfected.
So what can you tell us about partner treatment and expedited partner treatment if that's necessary?
Yeah, so Dr. Marietta talked about that briefly earlier. Expedited partner therapy essentially gives a provider permission to prescribe for a patient that they don't have an existing relationship with. So in North Carolina, according to the Guttmacher Institute and the CDC, I just looked this morning to make sure it hadn't changed, expedited partner therapy is clearly allowable for chlamydia and gonorrhea. Trichomonas is a little bit more of a question mark. I can't find where it's been explicitly called out, which is, something we need to fix. So use your own judgment. I do expedited partner therapy for trichomonas because we see so much of it. But for chlamydia and gonorrhea, you can do it. Now, gonorrhea, the treatment involves an injection, so that's a little harder to do. But certainly for chlamydia, you can do it. If you're offering expedited partner therapy, make sure that you're documenting the name, date of birth, allergy status, and what prescription you generated in your patient note is a best practice. If you're in a health system, check your risk management team to make sure that they're going to support it. Because while it's very low risk to do it, some systems feel more antsy about it than other systems. So I would just check if you're part of a bigger system to see what your guidelines and rules are. Honestly, it's a really underutilized tool in our toolbox. And could be very beneficial.
So as we wrap up this conversation, I'd like to ask each of you to share what is your best advice for healthcare providers as they think about STIs and then their specific patient populations. Dr. Marietta, what is your best advice?
So having discussions about sexually transmitted infections offers us as a provider it's an incredible opportunity to show up for our patients in a way that makes them feel like really seen and heard and accepted and in like this safe and non-judgmental space. This is particularly true for patients who use substances. And it may be the first time. I hear this all the time from my patients. This is the first time that I've had an experience like this in medicine, that they can experience safety and judgment-free care. The language that we use matters. When we normalize testing and treatment and kind of walk with our patient down that road, it leads to the possibility of them trusting us and opening up about other things that may be going on and their other needs. This is truly how we change intergenerational patterns of trauma and substance use. I really believe that.
Yeah, I'll add on to that. I think the first thing I'll say is this is all of our responsibility in healthcare. Sexual health is all of our responsibility. If you're a neurologist, you're thinking about it because you're wondering if somebody has neurosyphilis. If all of us need to be thinking about sexual health. This is not just a primary care problem. Don't make assumptions about your patient's sex lives. Ask the questions and ask them often. And particularly sites of exposure. I see so often people that come into the clinic saying, "Oh, I was tested and everything was okay." But they weren't tested in all the sites they were exposed to. And in fact, they weren't okay. They had infections. So the last thing I'll say about this is if you don't understand what somebody is saying, stop them and ask them to clarify and don't be embarrassed. This happens to me all the time. There's constantly changing vernacular. Now it helps that I've got like 2 now sort of young adult-ish, adolescent-ish boys, and I hear their friends talking, and so I learn some of the vernacular. But it happens all the time when somebody says something in clinic that I don't understand. I had a guy come in once. He was dressed all in camouflage, and he was sort of this mountain man-looking guy. And he said he was a contact of syphilis that he'd gotten from a bear party. Well, my first thought was he was hunting bears and got syphilis? Like, I don't even get this. Well, he had to explain to me what a bear party was. And it was not about hunting bears. But, I don't know. It seemed reasonable. But I find that people are more than happy to explain the terms that they're using and help you do better. And honestly, you expressing your vulnerability of not understanding something really creates a safe and accepting space for your patients. So test all the sites, ask all the questions, and ask them often. And don't be afraid to ask for clarifications.
This has been very eye-opening and is all a lot of great advice in this podcast. So thank you again both for your time. Thanks to our listeners for joining us. And if you like this podcast, check out some of our other episodes in the Governor's Institute Addiction Medicine podcast and be sure to subscribe. So thank you both. We appreciate your time.
Thanks so much.
For having us.